And I want to thank you all for joining us today. The subcommittee will come to order. My name is Brad Winstrup, and I am a veteran, a doctor, and a congressman from the 2nd District of Ohio, and a member of the U.S. House of Representatives Committee on Veterans Affairs. And I'm here today as the acting chairman of the Subcommittee on Health, and I'm so grateful to be with you here today in Southern California. Actually, my notes said sunny California, but that's not what we have today, but that's okay. Good. I'm accompanied by your Congresswoman and the ranking member on the Subcommittee on Health, Julia Brownley, and my friend and colleague. As many of you know, Congresswoman Brownley is a reliable advocate for veterans and their families, and her focus on the committee has always been finding ways to improve the lives of veterans at home here in California and across the country. I'm grateful to her for her hard work and for inviting me to be here with her this morning. Before continuing, I would ask all the veterans in our audience today to please stand, if you are able, or raise your hand and be recognized. Thank you all so very much for serving, and it's an honor to have you here today. We're here today to continue our mission of improving the Department of Veterans Affairs healthcare system and to ensure that you and all those that have fought, served, and sacrificed for our country receive the care that you have earned and deserve. As a veteran and doctor, I understand firsthand the importance of providing timely and high-quality care to our nation's heroes. And as a congressman and a member of this committee, I have seen time and time again where VA has sometimes come short to provide such care to veteran patients. There's a lot of positives. We have a lot of great providers, people out there wanting to take care of our veterans. Sometimes it's the system that fails us. So getting VA health care on the right track requires us to use every available tool at our disposal to increase access to care. Now, one of those tools is telemedicine. Telemedicine is the process of using telecommunications technology to remotely diagnose and treat patients, and it has obvious advantage for veterans, particularly for those in rural or medically underserved areas, or for those who have difficulty traveling to a VA medical facility. For example, using telemedicine could allow a veteran at the Oxnard Community-Based Outpatient Clinic, the CBOC, to see a specialist at the West LA VA Medical Center without having to fight traffic there and back. VA purports to be a leader in the use of telemedicine, and according to testimony VA will provide this morning, there were more than 2 million telemedicine visits across the VA healthcare system last fiscal year alone. The Commission on Care recognized that the VA is excelling at telemedicine and recommends that they expand the use of it. As the use of telemedicine continues to expand, we need to be sure that VA is keeping pace with modern technology and is effectively safeguarding private medical information through secure data channels. We also need to explore whether VA is effectively tracking telemedicine appointments to ensure consistent, quality care and monitoring patient outcomes. If VA truly is the leader in deploying telemedicine, it is important to track best practices, lessons learned, and the impact telemedicine is having both on individual patients and on the VA healthcare system as a whole, as well as to ensure that this technology is being leveraged to address the critical issues VA is facing today. For example, VA touts telemedicine as an important way to increase access to care. That may be true, but one can't help but notice that while the use of telemedicine has been increasing over the last several years, patient wait times have been increasing in some areas as well. And why is that? More importantly, how can we better utilize telemedicine technology to improve the care and the experiences that our veterans receive? I look forward to discussing these questions this morning, and I now recognize Ranking Member Brownley for her opening statement.
Thank you, Mr. Chairman, and thank you, Mr. Chairman, and really thank you for joining us today and traveling here to Ventura County for, I believe, an important hearing that's going to take place. I appreciate you coming all the way from your hometown, Cincinnati, Ohio, and I do welcome you to sunny Camarillo because the sun will indeed come out, and we are really, really happy to have you here. And I want everyone in the audience to know that Dr. Winstrup is an extraordinary member of Congress. We were elected together. He is an MD, as he mentioned, but also has served in service as a medical doctor. He is an Iraq veteran, and I think, like your district, my district is a district that is very rich because of its military families and veterans. So I think we both represent very, very unique and districts, because I think the fabric of our community is, as I said, very, very rich due to all the military families and veterans who live here. I want to thank our witnesses for joining us today to discuss this important issue. As technology continues to improve, the possibilities for providing health care are also rapidly changing. Companies and providers, many of them from California, I might add, are pushing the envelope on how we approach healthcare. One example of this is the growth of telemedicine, telehealth. So what does that really mean? And Dr. Winstrup just defined what telehealth is, and the Health Resources and Services Administration defines it as the use of electronic information and telecommunications technologies to support long-distance clinical health, patient and professional health-related education, public health, and health administration. These are innovative technologies and systems that can make healthcare more accessible across geographic locations. It can break down barriers between healthcare experts and patients who may be in different cities, different states, or even the other side of the globe. Today's hearing will focus on the use of telehealth within the VA healthcare system. As we know, there is not a one-size-fits-all approach to providing healthcare to veterans. The VA healthcare system serves nearly 9 million people, men and women, with different needs and preferences about their healthcare. Telehealth services are available for the VA to make diagnoses, manage care, perform checkups for veterans who may have trouble accessing their local regional medical center, or for those who need an appointment with a specialty provider not available locally. In 2015, the VA provided by far the most federal telehealth appointments, with 2.1 million consultations to over 677,000 veterans. And the VA expects the number of telehealth appointments to increase by over 12% in the coming year. I am looking forward to learning more about what the VA is doing to give the program greater visibility and what benefits they anticipate from the use of these technologies. I'm also interested in knowing how the VA is getting the word out about the availability of telehealth at the remote clinics, how veterans are being notified that telehealth is an option, and what strategies and technologies from the private sector the VA can look at to promote telehealth. Expanding telehealth appointments is especially important when we consider the ongoing provider shortage at the VA and across the healthcare sector in general. Secretary McDonnell has testified about the VA provider shortage and the need to recruit doctors and other medical professionals to address this shortage. We also know that there is a provider shortage, not just at the VA, but really throughout the nation. We should look at ways that telehealth can help mitigate this challenge and connect doctors and specialists with the patients who need them, regardless of geographic location. Again, I am looking forward to learning more about the VA's approach to telehealth and how this approach fits together with the ultimate mission of providing quality and timely care to our veterans. Here in Ventura County, we struggle with a community clinic that is still too small to serve the needs of all of our veterans. Although we are working diligently to address this problem, the VA Choice Program does not adequately take into account driving time for veterans to access care. And as we all know, traveling the 101 to Sepulveda or West Los Angeles for an appointment can take the better part or all of one's day. So it's particularly important to me that Ventura County veterans have access to advanced technology like telehealth that will increase the quality and timeliness of their care that they have earned and deserved. Thank you, Mr. Chairman, and I yield back the balance of my time.
Well, thank you very much. We're going to begin today's hearing with our panel of witnesses who are already seated at the table. And I'm going to yield momentarily to Congresswoman Brownley to introduce our witnesses. But first, I'd like to thank them all for their presence and participation here this morning, and for their service and for the work that they do for our veterans. I would also like to gently remind all of our today's witnesses to please be mindful of the 5-minute time limit for your oral testimony and the question and answer period that will follow. The light has been placed in front of me and in front of you and changed from green to yellow when there was 1 minute left, from yellow to red when the time has expired. So we're going to try and stay as close as we can to the 5-minute time limit as possible so we can be sure that everyone has a chance to be heard. And I want to thank you in advance for that consideration. Now, Ranking Member Brownley, would you please introduce our panelists?
I will indeed. Thank you, Mr. Chairman. And again, thank you for coming to this great county for our hearing today. And I appreciate your travels coming here and looking forward to a great hearing. And I'd like to welcome all of you here today, and I'm looking forward to discussing this important topic. We have a great panel of witnesses here with us who have graciously taken the time to share their perspectives on this topic. I'd like to take a moment to briefly introduce our witnesses. Joining us today from the VA are Dr. Kevin Galpin, the Chief Consultant of VHA Telehealth Services. He is responsible for overseeing the implementation and coordination of telehealth technologies throughout the VA. With him is Dr. Hartroff, Chief of Staff of the VA Greater Los Angeles Healthcare System. And also joining us today is Dr. Herb Rogov, the President and Chief Executive Officer of C30 Telemedicine, based here in Ventura County. And last but not least, also is here is Dr. Zachary Walker.
Doctor.
Walker.
Yes, Zachary Walker, Mr. Doctor.
Mr. Pardon me?
I thought you said doctor.
Oh, maybe. Mr. Zachary Walker,
Oh,
a U.S. Navy veteran, most important title, and Ventura County Probation Agency employee who will share his personal experience using telemedicine at our local VA. So thank you all for being here, and for audience members who are interested in sharing their comments or perspectives on telemedicine at the VA, my staff will be available after the hearing. They will be happy to take down your contact information and let you know where you can submit written comments that we will then share with the Veteran Affairs Committee back in Washington. So thank you very much, and I yield back.
Well, thank you. And we will begin with Mr. Walker. Sir, you're recognized for 5 minutes.
Good morning, and thank you for the opportunity to give my testimony with my experience with telemedicine. I'm Zachary Walker, a veteran of the United States Navy, 1975 to 79. My introduction to telemedicine was presented to me by my VA medical clinic, not as an option, but as a last resort. My journey began when I received a phone call from my local VA clinic one day before my scheduled appointment that my appointment had been canceled. The clinic informed me that my health care provider was not available. I was told the next available appointment would be within 2 months. Having already waited 2 months for an appointment, I requested to see the next available health care provider. Again, I was informed that the wait time would be 2 months because they were all booked. I took the next available appointment, now having to wait 4 months to see a provider. I terminated the call feeling frustrated and angry that my health care was being jeopardized due to the backlog in the system. The next week, I called my VA clinic and asked to speak to a supervisor who was not available. I then provided my information for a return call. Not having received a return call for 2 days, I again called the clinic and spoke with a supervisor. I reiterated my story, but it was apparent that she was unable and unwilling to help. She gave me some unclear information about how to proceed if my condition worsened, which I felt was not a solution to my problem. Out of desperation, I called my local VA representative and explained my situation. To my surprise, I received a call the next day from a clinic nurse who presented the option of telemedicine. Initially, I was reluctant because being seen by a doctor through a monitor was counterproductive to any medical experience I had in the past. The nurse was thorough, explaining the process and assured me that the doctor would have my lab results, and she would also review my medical history. I scheduled an appointment and was seen within a week. I arrived for my appointment and was escorted back to an examination room in a timely manner. I was seated in front of a monitor and a two-way camera. The doctor introduced herself. She was very pleasant, did not appear rushed, and she was well prepared. It was evident based on her questions that she had reviewed my recent tests and medical history. During my appointment, the doctor ordered more tests and made a referral for a new medical condition that she noted. She even apologized for not having the ability to examine me. Even more surprisingly, I received a call from her 1 week later with my test results. In conclusion, I had a great experience with telemedicine. My appointment wait time was reduced from 2 months to 1 week. My appointment started on time rather than the normal 1 hour lobby wait time. The doctor was not rushed during my appointment and took the time to listen to my concerns. The only obvious drawback is not having a doctor to physically examine you, but I would use telemedicine in the future. Telemedicine should be presented to veterans as an option for medical care and not as a last resort. Thank you very much.
Thank you, Mr. Walker. Dr. Rogout, you're now recognized for 5 minutes.
Thank you, Acting Chairman Winstrup and Ranking Member Brownley. It's a great privilege to be able to appear before the committee and testify about telemedicine, and in particular, the critical role and contribution to the VA telehealth system. I'm a physician founder of C3O Telemedicine, located in Ojai, California, Ventura County. And when my company was founded, it was founded upon the principle that Americans should not be penalized for gaining access to health care based upon geography, whether it's rural or inner city areas. To that end, we provide acute stroke care through telemedicine at over 30 hospitals across the country, including the great state of California. Additionally, I have served as the Secretary-Treasurer of the Board of Directors for the American Telemedicine Association, and I might mention that the current president is General Peake, former VA Secretary. In January of 2015, Mr. Carl Blake with the Paralyzed Veterans of America testified before this very same committee. And just to paraphrase him, he stated that the viability of the VA healthcare system depends upon a fully integrated system so that veterans get the care that they need when and where they need it in a user-friendly manner. I think the VA telehealth program addresses his comments. For the past 10 years, I have studied many telehealth models and have been most impressed by the VA model as both exemplary and successful. This past May, I had the privilege of meeting with Dr. David Shulkin, Undersecretary of Health of the VA, at our national meeting. And he provided us with some key elements and statistics that some of you have just mentioned, that over 2 million telehealth encounters. It affected 12% of the total VA population. 45% of those encounters occurred in rural areas, therefore precluding them to waste time to go for a 10-minute visit, which might take 2 hours in both directions. And more importantly, the outcomes, which in medicine we always want to know what kind of outcomes there were. In 2015, home telehealth reduced hospital bed days by 58%, hospital admissions by 32%, and the use of psychiatric beds by 35%. So looking at the future, the VA telehealth model has a tremendous opportunity to, number one, provide the continued leadership in developing a system-wide telehealth network. Those of us in the private world of telehealth look at that as an exemplary model, something that we should strive for. We have the opportunity to develop public-private partnerships, in particular, as was previously mentioned, the shortage of physicians. We currently provide, as a private company, to some major universities around the country to fill in the gap for shortage of neurologists that universities don't have. I can see that happening between the VA, companies such as mine and others, major systems like down the road UCLA, which is developing a telehealth program, etc. We need to push for CMS to expand reimbursement for telehealth, particularly to metropolitan statistical areas, which essentially is urban areas. Right now, Medicare laws do not pay for telehealth in urban areas. Fourth, the establishment and criteria for adequate, accurate, and safe consumer technology that can serve our homebound veterans and patients. And finally, something that's really, really important from my perspective, and that's to deal with the interstate licensing. The VA, the military, has the phenomenal ability to have one license to practice in 50 states, just like you have one license to drive from California to New York or Cincinnati. Right now, it costs over $600 million to pay for it. The exorbitant amount of time. It's a 100-year-old system that's antiquated, and the state medical boards sometimes may not be looking at the best interest to get programs out and function, and hopefully we can address that. So once again, thank you very much for allowing me to appear before you today.
Thank you, Doctor. Dr. Galpin, you're now recognized for 5 minutes.
Good morning, Mr. Chairman, Ranking Member Brownley. Thank you for the opportunity to discuss the efforts the VA has taken to develop telehealth, the services VA provides veterans through it, and its expansion. I'm accompanied today by Dr. Scotty R. Hartron, Chief of Staff of the Greater Los Angeles Healthcare System. VA is recognized as a pioneer in the practice of telehealth and has used telehealth to substantially increase healthcare access for veterans. Since 2002, 2 million veterans have obtained some of their healthcare through telehealth services, and the number of veterans utilizing these services continues to grow. In fiscal year 15, VA conducted over 2 million telehealth visits, serving almost 700,000 veterans. The mission of VA telehealth services is to provide the right care in the right place at the right time through the effective, economical, and responsible use of health information and telecommunications technologies. Telehealth changes the location where healthcare services can be provided, making care accessible to veterans in their local communities, in their homes, and even in their pockets on mobile devices. Equally critical, it allows services to be delivered from any location, allowing the VA to hire providers in large metropolitan locations in order to serve veterans in areas of provider scarcity. Leveraging telehealth affords the VA an opportunity to increase access, especially for those veterans in rural or underserved areas. The VA currently offers over 50 types of clinical services through telehealth. Of the services offered through video conferencing, telemental health is the most heavily utilized and is also an area of strategic growth. For context, more than 2 million mental health visits have been provided to almost 400,000 veterans since 2002. VA has found telemental health to be equally effective, if not more so, than in-person appointments. This exemplifies a patient-centered model that efficiently brings mental health care to veterans who might otherwise need to travel significant distances to obtain such care. In 2016, building on the success of the existing telemental health program, the VA is establishing 4 regional telemental health clinical resource centers. The goal of these centers is to expand mental health provider services at rural facilities where recruitment of providers can be challenging. When fully staffed, these resource hubs are projected to provide an additional 65 to 82,000 mental health visits per year at locations of need. VA also manages a national telemental health specialty consult center. This center has a virtual clinical team comprised of leading national experts in specific mental health conditions who can be located anywhere in the country. These providers are able to deliver their specialized mental health consultation services to locations in the country, to any locations in the country, to assist veterans with the most complex conditions. This center has delivered services to over 4,600 veterans at over 120 locations. The VA continuously adds new telehealth specialties and services as technology improves. For example, Teleintensive Care is a telemedicine program that links intensive care units in VA medical centers to a central monitoring hub staffed with intensivist physicians and experienced critical care nurses. Through the use of cameras mounted above each patient's bed, along with links to the medical record and vital sign monitors, staff in the TeleICU hub not only see all the pertinent medical data on a patient, but they are capable of performing audiovisual exams, discussing treatment plans with patients, nurses, and families, intervening during emergencies, and generally providing specialist-level care and consultation to the local staff. TeleICU does not replace the local ICU care team, but adds specialist resources and another set of expert eyes to watch over our most critically ill veterans. Looking forward, the VA is excited to expand a teleprimary care model similar to telemental health that will bring virtual primary care providers, social workers, psychologists, and pharmacists into rural sites where needed. VA is also developing the VA Video Connect application, which can provide a fast, easy, encrypted real-time video connection between a veteran's personal mobile device or computer and a provider. VA recognizes we are still at the beginning of our journey to best leverage our integrated national healthcare system and remote care technologies. VA would be able to accelerate this expansion and leverage new opportunities if our clinical and technical capabilities to deliver outstanding health care through virtual technologies were unambiguously supported by legal authority to deliver clinical services, irrespective of the veteran or the provider's location. VA is a leader in providing telehealth services, which remains a critical strategy in ensuring veterans can access health care when and where they need it. With the support of Congress, we have an opportunity to shape the future and ensure that VA is leveraging cutting-edge technology to provide convenient, accessible, high-quality care to all veterans. Mr. Chairman, this concludes my testimony. Thank you for the opportunity to testify before the committee today. We appreciate your support and look forward to responding to any questions you and members of the committee may have.
Thank you, Doctor. Dr. Hartoff, you're now recognized for 5 minutes.
Okay. Good morning, Mr. Chairman and Ranking Member Brownley. Thank you for the opportunity to discuss the efforts that GLA has taken to develop, deploy, and expand telehealth. In fiscal year 15, GLA provided 20,000 telehealth visits to over 6,000 veterans. GLA uses all telehealth-related modalities to include clinical video telehealth, store and forward technology, and home telehealth. Clinical video telehealth involves a clinical provider and a patient interacting via video telecommunications, such as telemental health, while store and forward technology takes digital images that can be reviewed remotely by specialists, such as things with diabetic retinas being examined by an eye specialist or a suspicious-looking mole by a dermatologist. And then lastly, the home telehealth, which allows prompting and monitoring for chronic diseases such as diabetes. GLA currently has 34 different telehealth clinics available that range from audiology to mental health. At the Oxnard CBOC, we currently have 7 different telehealth clinics, which include different types of mental health clinics, such as general mental health, PTSD, compensation and pension, and others. A major focus at GLA is to improve access for our veterans, and the use of telehealth services is one way to help do that. One example is in May, GLA began a pilot teleprimary care program at the Oxnard CBOC. Since GLA did not have a teleprimary care program at the time, this pilot was set up specifically to help address the primary care access demand at the Oxnard CBOC. This pilot was not to replace traditional face-to-face primary care provided at the CBOC, but as a supplement, while additional needed primary care staff were being recruited and hired. Due to the pilot's success in improving access to primary care at Oxnard, GLA has made arrangements to continue providing teleprimary care services until the traditional primary care clinical access reaches a stable and improved state, and provide another option for veterans based on their preferences. Another example of how telehealth programs can improve, as previously testified, is the chronic disease states that we use with the home telehealth. And veterans enrolled in home telehealth in fiscal year 16 have had a decrease in home admissions 6 months after being enrolled when compared to how often they were requiring hospital admission before enrollment. GLA is currently reviewing the demand for telehealth as well as face-to-face services and implementing action plans to continue improving access. Specifically for the Oxnard CPOC, GLA has recently added teleaudiology and a face-to-face audiology technician to help with hearing aids. Additional face-to-face specialty care services are scheduled to begin soon at the Oxnard CPOC to include cardiology, cardiac echocardiography this month in August, gastroenterology in September, and physical therapy in October. In conclusion, telehealth will not completely replace the traditional face-to-face clinical care, but GLA is adding additional telehealth resources to improve access to care for veterans by supplementing traditional face-to-face clinical care when, to whom, and where appropriate. Mr. Chairman and Ranking Member Brownley, this concludes my testimony. Thank you for the opportunity to testify before the committee today, and we appreciate your support and look forward to responding to any questions you or others may have. Thank you.
I want to thank you all very much. At this time, I'm going to yield myself 5 minutes for questions. And then I want to start with you, Mr. Walker. You mentioned that it was telemedicine was offered as a last resort.
Correct.
And could you expound on that a little bit? And what would you say to veterans who are becoming aware of telemedicine as a possible choice for a method of care?
I say, when I spoke on it being a last resort, I've used healthcare since I got discharged from the military in 1979 up to this last episode, and I have never been introduced to the thought of telemedicine. I think it was through my frustration and my pushing to get some adequate care that it was presented to me as a last resort, not as an option. Maybe if it was presented to me early on in the process when I was given a 2-month time frame to see a doctor, and it might have been a more positive result, but me pushing, then it was like a last resort. I say for any veteran that may be going in there for normal testing, doctor spoke of diabetes, any related tests that you normally go through and you want your results in a timely manner, that's a good option. Any kind of medical condition that doesn't necessarily preclude a doctor actually putting hands on to you, I think is an outstanding idea. I'm glad it was introduced to the VA.
Thank you. So in that context about him feeling it was a last resort, as this is developing and growing, my question for Dr. Galpin, if you would, in terms of expanding telemedicine throughout the VA system, what kind of an algorithm do you anticipate? Is there one in place? Should we put one in place for that being an option rather than, hey, you know what, we got somebody on the phone who's kind of upset their appointment got canceled, let's throw that at them. Is this going to be part of an algorithm that is an option up front for people, and what does that look like, and will that be sort of VISN to VISN or a national program?
I appreciate that question. So right now, it's actually very much part of our strategic plan to help develop the capacity of telehealth. And so we've discussed a little bit our telemental health hubs and the primary care hubs we want to develop. Those hubs will serve as essentially an interim staffing program for facilities. So if a provider leaves and a veteran is left without a primary care provider or without the resources of a mental health provider, we will have resource centers that can help out and fill in on the staffing levels. So that's kind of the regional level and the type of help we can provide to each other across an integrated healthcare system like the VA. In addition, we want to see telehealth being used on a day-to-day basis in the regular practice of medicine. So when a veteran comes into a clinic and they need the retinal screening, we want to make sure we have that option available. We want to make sure we have the dermatology option available in every clinic. It doesn't necessarily have to all be through telehealth, but we have the capability now of offering services in a standard way across the board at convenient locations that we didn't have before. So we want to integrate those practices and really take advantage of that.
Well, the question I have though is if someone calls for an appointment and they're being told, you know what, you can be seen in 3 weeks, here at the VA. When they make that initial call for an appointment, might they not be given that option right off the bat, is what I'm asking.
Yeah, and I think if the services are available, I think that's the key question. So at this point, we're still expanding our telemedicine programs. And we have a lot to do. We're still at the beginning of a journey, and this is one of those areas that we are seeking help from Congress so we can more rapidly increase our program. But if the services are available, then we have the opportunity to leverage those services for the individual patient when they call in. We first have to get to the point where they are available and we have that resource sharing capability.
So, and let me go to you for a second, Dr. Rogov, when you were talking about the licensure across states and things like that, because currently to be a provider at a VA or federal facility, you just need a state license, and then you apply and credential as you normally would. So if someone is in a different state, but they are credentialed to the VA, is there a barrier for someone in Ohio to take care of someone in California via telemedicine if they have credentialed with the VA in some way?
Specifically the VA?
Yes, particularly to a federal agency.
Yeah, my understanding is, yes, they have the capability of being a physician licensed and one taking care of a patient in another state.
If you have gone and credentialed through the VA.
Correct.
Itself, right? Okay, so there is an option to be able to do that.
That's my
You
understanding.
want to say something, Dr. Galpin, on that?
Yeah, so it's actually, this is, I think, what we're seeking from Congress on this, is that actually the laws are somewhat ambiguous in this area, and it's one of our major barriers to being able to expand services quickly. So you're correct, if I have a license to practice in a state and I'm licensed in Georgia, I can go to a VA facility and I can provide care at that facility for veterans. It gets ambiguous when you take that provider outside of VA property, where you take care of the patient outside of VA property. So if you look at the way we want to leverage this type of technology, we can overcome space barriers and use alternate work sites and set up providers quickly in their homes without having to build new spaces, or take care of veterans in their homes, or as they're on their mobile devices going across country. It's not clear. And so that's really what we're seeking is an unambiguous law that says VA providers, irrespective of our location or the veteran's location, can take care of our patients. That's our major ask.
It sounds like you're seeking seeking for us to codify this to some degree and say, look, because I've always felt, especially as we put choice in place, you can be a VA doctor, you don't have to be within those walls of the VA. So if you're a VA doctor in Ohio that participates in the telemedicine program, whether you ever go in within the walls of the VA, but you are credentialed by the VA, then you can do that anywhere in the country for one of our veterans. And am I on track with what you're seeking to clarify that or make that available?
That is what we're looking for. Again, I want to be able to provide care regardless of my location, regardless of the veteran's location. And it's, we're looking for, I think, a pretty straightforward legislation that gives us that authority that we essentially already have within our own buildings. And we just need that within the legislation.
Gotcha. I now yield to Ms. Brownley. I'm sorry, did you want to add something to?
Yeah, I do. It's just briefly. It's interesting. CMS just released the fee schedule for 2017, and in it they're redefining where the telehealth. The way you look at telehealth, there's the originating site, which is the hospital that's requesting where the patient is, and there's the distance site, which is where the telehealth doctor is. The way it works right now is it's the patient-centered, which means you're crossing state boundaries and need a license. However, what CMS is now proposing is that it's based upon the distance site where the physician is. In other words, that physician in California can take care of a VA patient, whether it's at their home or in the VA hospital in the state of Ohio. So this is something that's, the proposal was just released a couple weeks ago, and this will change the game a bit and maybe give us some leverage.
Thank you.
Well, that's very new information that I wasn't aware of. I just wanted to follow up with Mr. Galpin on the line of questioning, though, in terms of solutions for expansion of these resources. Is it that simple, really, just to pass a piece of legislation that says you can do it, or is it more complex and interwoven with all of the various states and their licensing and so forth and so on? So, if it sounds to me like what you're expressing is something that is, pretty simple. I mean, I served in the state legislature in California, and boy, scope of practices issues were oh my goodness. You know, you pass a committee room and that's where you had 50 people standing in line to testify in the committee. So I just want to make sure that it is something as straightforward and relatively simple to resolve this issue.
Yeah, I would say, I think with pretty simple clarity, I do think it is a simple solution from a legislative standpoint. As a lot of people already assume, there's kind of an understanding or belief that the VA already has this express authority. And again, it's ambiguous. We in some people's eyes have the authority, but it's not codified. We can't point to legislature and say, listen, we can do this. And so when we want to set up telemedicine hubs and move providers from where we have relative abundance to where we have relative scarcity, it becomes this large legal question, and it really slows us down, and in some cases, it hampers us from moving forward quickly. So yes, I think there is a fairly simple solution that can be provided that will significantly help us expand.
When we're seeking providers in a network here, it's Tri-West. So they're sought out and approved based on the standard within VA. That's the one central standard that is across the board nationally. That's correct, right?
Can you clarify the question on that?
Yeah, so as we recruit providers for the choice program, for example, for veterans to be able to use doctors in their communities rather than the VA, if you know, based on the criteria now is you know, if you can't get an appointment within 30 days and the 40-mile rule, although all of our veterans here know that the 40-mile rule doesn't apply to us here in the county. We keep trying to fix that, but we haven't achieved that yet. So all I'm saying is that when they are recruited to be community providers for the VA, are they approved by the VA by the same standard by which you approve doctors within the VA?
Okay, so one piece that I just need to clarify. So when we're talking about our telemedicine program, we're actually talking about providers that are hired or work directly with the VA.
Correct.
So we bring them into our system, we go through the same process to credential and privilege them. They have to be credentialed and privileged at a VA facility. So they go through the same standard, plus then they get additional training to become telemedicine providers so they can serve in that capacity. So yes, the standards, and that's the foundation of our program to make sure we can provide quality services.
Right. So you're not talking about expanding telehealth to our community partners?
No, I'm talking about the authority for VA providers to provide services to veterans.
Okay, all right, very good. So I wanted to go back, you know, to our CBOC here in Oxnard and serving our Ventura County veterans. So, if you could describe to me, Dr. Hartroff, exactly. My understanding is there's sort of 3 pillars of telehealth services. And if you could describe to me, are all 3 of those pillars embedded into the Oxnard CBOC, or are we not there yet?
Yes, all 3 are currently available at the CBOC, the CDT, which is the clinical video teleconferencing, the Store and Forward, which is teleretinal, and then also with the home telehealth, which are the monitors that people have at home that remind them of chronic disease.
So the Store and Forward telehealth is there?
Yeah.
And Store and Forward telehealth, how does that synchronize with electronic medical records? Once you have that data, is it merged permanently into the record of the veteran?
That's the nice part, is it does merge into a part of CPRS where it can be viewed, and the notes taken by the reviewer at the remote site directly into the records. And imagine, you know, not having to send slides off to a far distant university that sometimes people have to do. This could be real time, literally the next day, where it arrives, the person reads it, and it goes right into the record and available for the provider to see the next day. So it's really a very timely modality when one thinks of the traditional means of sending out that most facilities do if they don't offer in-house services.
Very good. My time is up. I will leave it back.
We'll go another round.
Sure. Great.
Dr. Roga, If I can get from you your opinion on how we can better partner telemedicine practices like yours and increase the availability of telemedicine to the VA.
Yeah, I think one of the examples I mentioned briefly alluded to was the fact that capacity is really important right now for health systems, and I think you have physicians, let's say, in an academic medical center or a VA system where they have responsibilities, on-site responsibilities, clinic responsibilities, education responsibilities, and now you're adding on a telehealth responsibilities. There's so much you could get out of the physicians to do that. And it's predicted that we're going to be, by the year 2025, we'll be probably 90,000 physicians short, a little bit less than we thought. So in an effort to do that, I think this is where the public-private partnership comes in. Universities used to be on one side, the VAs on another silo, and there's private enterprise on another silo. If certain facilities have the capacity to help another facility or system, I think now's the time that we start to do that. And our case in point is that we just got a big contract in northern New Jersey. It's 2 academic medical centers together with a bunch of rural and community hospitals. And they just don't have the capacity for their physicians, their neurologists in particular for stroke. And they've solicited us to come in there and help solve the problem. And while we are not physically present, we help to augment their practice. And euphemistically, I say it's like having a partner without having to provide a 401k for you. They're there to help you and do what's necessary. Night call, weekend call, vacation call, to help alleviate the burden and prevent more burnout. So I think there's a tremendous opportunity and drop the barriers between academic, government, and private and bring us all together and find out where the resources are and redeploy them.
I mean, ultimately, our goal is to get care to our patients. In some ways, as referenced, is get help from Congress or get Congress to get out of the way and let those things happen. Dr. Galpin, credentialing process, this is always an issue, even at the CBOX. You lose a doctor and you try to replace them, and you may even have a VA doc from somewhere else who wants to come to your CBOC, and he's got, several months credentialing process to go through, rather than being able to just say, look, I already work at this CBOC over here, why can't I just come in and start working there? But the credentialing process for telemedicine, for example, how is that operating? And are there any flies in the ointment there that you want to address?
So, credentialing privileging, of course, is a foundation. One of the key ways that we maintain quality services. We have the authority within our integrated healthcare system, which is really a key for us to being able to do this so efficiently, to share privileging decisions from one facility to another under joint commission. So if I am privileged at the Atlanta VA and I want to work through telemedicine in another VA facility anywhere in the country, the other facility does not need to go through all the primary resource verification that takes a tremendous amount of time, but they can develop an agreement that essentially says, yes, we trust the other facility that they are utilizing the processes they're expected to be utilizing under the Joint Commission and VA policy to do the right thing, and so we accept this provider as a provider that can provide services to our patients. As a piece of that then, that provider needs to be monitored. There needs to be a bi-directional exchange of information between those facilities to make sure that the provider is competently performing their privileges after the fact. But that is a process that makes it easier to move resources from one place to another.
I appreciate that. Mr. Walker, I have a question for you. When is your next appointment with the VA?
Personally, I don't have one scheduled.
Okay.
I'm go through the process of the referral that the doctor made for me, so not with my primary care clinic, but I do have one in the Valley off Plummer, so.
Do you plan on your next primary care visit to be through telemedicine unless you feel a need to be physically examined?
Well, I'm not sure. I was told later that my primary care physician retired, and that I do not at the present time have one assigned to me, so we'll move forward and hopefully it'll go a lot smoother transition than the last.
Okay, thank you. And
Well, thank you, and I want to again sort of harken back a little bit to the Oxnard CBOC, because I know there are many veterans here in the room who utilize that facility. So I want to be as transparent so everyone in this room knows that we have gone through some growing pains at the Oxnard CBOC. We have expanded the physical footprint of the CBOC, and once we did that, then we were understaffed for a while, and now I think we are at a point where we're now fully staffed and beginning to expand some specialty care services in the CBOC. So we're just sort of getting there in terms of a larger space and fully staffed. And I think that telehealth is going to be a critical component in the services that our CBOC can offer. But I want to be clear that, if our veterans are calling up for appointments or coming into the CBOC for an appointment, I think at this particular point, most of our veterans are expecting that they're going to see a doctor and there's not going to be another course or avenue for them to go down. So, it's the educational component here. I want veterans to understand that if they want to see a primary care doctor in the CBOC, they can see a primary care doctor in the CBOC. I don't want them to think that we're talking about all of this to substitute the traditional doctor-patient relationship and those visits. So. But I do think, and certainly based on Mr. Walker's testimony, that there is a large learning curve that's going to take place. I think probably some of our older veterans are going to be a little leery about using technology around their health, because that's a new concept for them. I think our younger veterans might be more susceptible to it and open to it. I think that once we understand how telehealth can augment their healthcare services, and particularly to understand that this could eliminate those follow-up travels to Sepulveda or West LA, that can be done in the CBOC, seeing a doctor face-to-face, and perhaps even your doctor sitting with you in the examination room. I think people then, their sort of fears and misunderstandings about what this all is can be alleviated and helped. So I just want to understand, and for everyone who is here today listening, and I think almost everyone in the audience here today is here because of their positive or not so positive experiences within the CBOC. So, if you could, just kind of walk us through a new patient who has never been in the CBOC before and what their experience might look like, and the experience of a veteran who comes into the CBOC, has been seen by a primary physician who may have diabetes or who may have heart issues, and explain what the procedures might be in those two pathways.
Okay. First of all, I would like to apologize to Mr. Walker for his experience with his first introduction to telehealth. Just to give a history with the telehealth introduction at the CBOC, I arrived as the new Chief of Staff on April 4th and noticed the demand was exceeding our supply currently. And within, by May 8th, we were seeing our first patient with teleprimary care. The problem with forward deployment in a rapid fashion of 4 to 5 weeks is, again, that education curve was something we definitely, again, that's the area I'd like to apologize for, because it's definitely something that gives another preference, another choice. It's not going to fit everyone, but it also was, again, giving them another choice to base that on. So that's kind of how we rolled that out, is to seeing that, because as you can imagine how much longer it takes to bring on other providers through the process, where one can see the problem after being here just a couple weeks, and then within 2 to 3 weeks actually having the first patient being seen by teleprimary care. For a new veteran, if they're coming into our system, as we are rolling out the education curve, is giving them, again, explaining the process to veterans as they're coming on as a new patient, just saying, what are your preferences? We have options. to include your face-to-face visit or a teleprimary care visit. And then they would actually be able to, our goal is to get that where they can choose one of those on their preference, and especially as we're building our capacity at the current clinic. So we definitely never want to replace face-to-face interaction with primary care. That's not our goal, but our goal is to give another option as we're bringing on the capacity. The nice thing is that we're adding peripheral devices, as we call it, where they can actually have a more interaction with the physician with like a stethoscope that the tech on their side of the patient can actually put to the chest of the veteran and can be heard well by someone remotely, and other devices so that they can do more of a contact physical exam. So largely for the veteran, as they come in, it will be preference choice as to which they prefer, and then some of it could be again, that option based on what may be available sooner until we get all the panels fully expanded.
And so when a patient comes into the CBOC and has an appointment, then in terms of follow-up, are the medical teams that are set up at the CBOC, are they trained to say, rather than you having to go, I need you to have these tests, but rather than having the test, but then not having to go back to West LA, or some, although we're gonna, if you're more willing, we will, we can have that follow-up meeting here in the CBOC through our technology, and you'll be able to see the doctor that you might have seen, or at least see the doctor or the specialist who can give you the results of these tests.
Yeah, and also one of the choices, a veteran may start off with a telehealth provider through teleprimary care, but then we'd like to give the option even at some point if they want to change over to an in-person face-to-face. So that's one of the things that we definitely like to focus on, and then we train with techs that we've expanded resources to where techs on each side are being able to better walk the veterans through the process, as Mr. Walker had explained, about bringing them back, doing their assessment by the nurse and bringing them in. So again, we're in that, teleprimary care was a new event, a new program, especially the Oxnard program, so we're definitely
And continuity of care, I know that that's an issue that veterans are very concerned about. If they have a health issue, they're interested in seeing the same physician, over the course of a treatment. So how do you get that continuity of care through telehealth?
Again, I think a lot of that is just the comfort and preference of the veteran as to if they don't mind seeing a secondary provider, if their doctor, they can't be worked into their doctor's schedule same day. A lot of times, as we've seen in private practice, sometimes you can see a provider, an extended provider, the same day, but they work with your provider and have the same record. So our goal is to, even the veterans who start off with teleprimary care, the option eventually would be to go to more of the face-to-face model, unless their preference is to strictly stay with teleprimary care. The nice thing, though, is with our electronic records and our ability to have all the information right there in front of us, unlike many closed systems in the private sector, it's really a lot more streamlined as to handoffs with patients. So a lot of it is really, we'd like to make it what they choose. As to, I don't want to make a template, one size fits all. I'd really like to have these decision trees based on their preferences and choices. So it's kind of hard to describe what it would be for every veteran.
Thank you.
You just touched on one of the things that I wanted to talk about, which is making this type of an option, the decision between the doctor and the patient on how they choose to proceed. And in my practice, I started practice in 1986, and in later years, I'd have a patient call. I treat a lot of diabetics. They have wounds, they have ulcers, they're worried, is it infected, this and that, and I could get on the phone and say, take a picture of it. let me just see it. And I might save them a trip in because it looks fine, or yeah, I need to put you on an antibiotic, and then I'll schedule you for follow-up in a couple of days. And so there's a lot of advantages that save time and money and really provide better care because you have that instant access rather than, especially somebody who's homebound. What a huge advantage these things can be, and in a simple way. So I would like to hear from really all of you, because my feeling in the ideal situation for the VA or for any healthcare system whatsoever, that everyone has a primary care doctor. And this is one of the things in my district that I saw was a huge value at the CBOC. You know, I'd go out in the lobby and I'd talk to the patients out there, and they love it. They love it because that's my doctor. I know who it is. I know this person. Rather than I'm going to the VA, I don't know who I'm going to see today. You know, who will be there, and it's a different one than I saw last time. That happens in any practice, but nonetheless, they feel like they've got someone where there's a relationship and some ownership. And so whether it's through telemedicine or through the face-to-face visit, you have that opportunity. And the other thing that I would like to see, and maybe if you comment on it, referral decisions should be between that primary care doctor and the patient only. We don't need another layer of bureaucracy. If you're hiring primary care doctors and you credential them, you must trust them to make decisions and the patients to make decisions with them. And that to me is one of the things that we are tying people up in bureaucracy, and it's time to move someone over. And I think you somewhat commented on, Mr. Walker, where you said, my doctor retired. And so I would imagine that you are very interested in meeting your next primary care doctor.
I would like to, yes.
Yeah, okay. But comment on those other aspects if you would. We can go down the line.
So my background is in internal medicine, clinical informatics, but I work as a primary care provider in the VA. And I agree with you. I think it's very important to have that one provider who is recognized as the face of the VA for the patient, who coordinates their care. I mentioned the teleprimary care hubs, this model where we can provide interim staffing. And what I really love about this program is that they commit a provider to work with a panel of patients. So again, if your provider retires and we have the option to bring in a provider, they commit to at least 6 months for that provider to take over that patient panel. So it's at least the same telemedicine provider until they can hire the new provider in the clinic. So you do get continuity. In addition, we have more than just the capability of bringing the provider in, but they have psychologists and social workers and pharmacists, so they can bring actually other members of the PAC team to some of the rural sites that may not have those resources. So it functions as a very effective interim staffing program. In addition, we try and hire those providers somewhat regionally located to where they're going to be delivering services. So even though their primary focus is on delivering teleprimary care, they do travel to those centers 1 week at least out of every quarter to provide some in-person appointments for veterans who may not be interested in having their care through virtual means. So we're really excited about these programs. We're really just getting started on setting up that model. I think it's a very exciting model, and it helped me overcome some of the barriers that I personally had as a former primary care provider. How will this all work, and will it fit all of our needs? So very excited, but I think it helps address some of the questions you have.
Doctor, do you have anything else to add?
No, I completely agree with that. In addition to, the nice thing with telehealth is even when someone has their established provider, the other modalities, the store and forward, they can potentially having the dermatologist help the primary care provider decide, like with teledermatology, whether that should, a suspicious lesion should be removed. And then also the home telehealth, which is very nice with chronic diseases and provides better information for the more data points for the primary care provider to base longer-term decisions over instead of single-point blood pressures when they come into the clinic, per se, or blood sugars. So the nice thing is you can, even if you're not in the CBT program where you're face-to-face, the primary care doc can actually use the other modalities to expand their care to others.
Ms. Brownley?
Yes, thank you. I have a question, and I'm looking for it here. So, Dr. Galpin, my staff made me actually aware of a report from the Commonwealth Fund, which noted that of patients who used VHA telehealth services between 2003 and 2007, that 96% were male and 4% were female. I was wondering if you can add something to that data point.
Yeah, so we looked at that information looking at our most recent fiscal year, so FY15, and We have about 7.4% of our veteran population being served in the VA are female veterans, and about the same proportion use telehealth services. So if you look at all the encounters, it's about 7.2 to 7.4% for our clinic-based telehealth programs and store and forward programs, similar to the home telehealth model. So it is a program that is utilized by female veterans, I think at about the consistent rate as with our male veterans. We've also got some programs that are uniquely geared toward female veterans. So we have there's actually a fairly long list, but women's health primary care, we have a women's health stress disorder clinic, OBGYN, and actually as of last week, we just signed a women's telehealth operations manual that will help facilities set up these programs, provide the guidelines, and basically how to get started. So it's certainly an area of focus. There's a lot of great opportunities in there, and I think we're beginning to really take advantage of those.
Very good. And in your testimony, at least in your written testimony, you kind of described these sort of three pillars of telehealth. And is it fair to say that all three of those pillars are available throughout the country, at every clinic across the country, every medical center across the country? Is that where we are in terms of scale?
So yeah, I'll have to spend a little bit of time on this question. So yes, the three general pillars are generally available across the country. People have clinical video telehealth services, and they have store and forward telehealth services and home telehealth services. From one location to another, though, the facilities may have chosen to invest in different types of offerings through those services. So you can't say, for instance, that every CBOC, every community-based clinic is going to have a dermatology program or a teleretinal program or this type of program. So the variety of the clinic is still a local decision based on what are the needs at that facility, what can that facility safely offer, what is the decision of the medical executive committee, and what are the needs of the veterans in those locations. So again, in general, yes, they're available pretty ubiquitously around the country. However, any individual offering, it's hard to say that's available in every location.
And are rural areas using it more than urban areas, or is it, pretty consistent or inconsistent across the country?
Last year in FY15, we had about 45% of our encounters were for veterans living in rural areas, so it's pretty split. I mean, there's a lot of advantages to doing it both in rural and urban communities.
Very good. And I think, Dr. Hartroff, you talked about, I think it was you that talked about consultation services. These are specialists. And so are those services, or hubs is sort of the way I'm thinking about them, specialty hubs, are they across the country? Do we have one in West Los Angeles?
We've kind of taken an approach with the new leadership of being data-driven and being strategic in the sense of what we've done is the veterans that we currently are looking at that drive to West LA or Sepulveda from Oxnard, we've looked at what type of services are requiring them to do so. And those are the ones that we're focusing on primarily first, whether it be face-to-face, and why we chose some of the programs we have. And then what we do is based on that demand and how many we calculate would be during a week to save efficiency with that provider in our grids, we decide whether the telehealth would provide enough. And so we're kind of using both face-to-face driven on supply demand and how we're seeing our current veterans having to make that trip is kind of how we're rolling it out. We're wanting to, I think we'll look a lot different down the road, but right now how we're choosing is just based off of what we're seeing the veterans from Ventura County having to make that drive to Sepulveda or West LA.
Very good. Well, it seems to me that we have Dr. Rogov here who is really trying to push the envelope in terms of private healthcare delivery, and he has barriers that the VA doesn't have. And I think it's fair to say that the VA has been a leader in telehealth, and I think the VA has a large responsibility to keep pushing and pushing that envelope, because If we are successful within the VA providing these services and proving really to the rest of the world that this is indeed the future and the most efficient way to provide services, most likely, and certainly in terms of physician shortages and so forth. And so I think we have a big responsibility to work not only with private industry and work with some of their issues, but we have a responsibility to be the trend leader here and to push the envelope. And so I think, I'm certainly more interested in, how we, to the degree that, we can continue to kind of keep pushing and pushing and pushing on this, particularly when, I think about specialty care or those veterans who have a particular kind of illness or an unusual illness where we really need expertise from, across the country, or a brain surgeon that there's only 3 in the country that perform this particular kind of surgery, and that we're really, continuing to really push. When I first was elected, I knew very quickly that we were providing mental health through mental health services through telehealth, and for some veterans, that's wonderful. They can be in the privacy of their own home. They don't have to come to an office and wait in a waiting room, and they feel more comfortable using telehealth for their mental health services. And to the degree that we can get more veterans utilizing our mental health services who need it, that's a good thing. So I want that, but I also want to really be kind of pushing on the edges, so that we can kind of break barriers really for and as we try to do in the Choice Act to bring community partners with the VA, that we can be community partners within the telehealth arena as well. And so, I'm certainly interested in following up and making sure that we're overseeing, the data on this and overseeing how we're pushing the envelope on this. And I'll bring that down to another level entirely, and that's the local level here, making sure that we're the education and so forth that I think needs to take place, that the CBOC is there so that people know more of their options. But, in terms of where we might be scaling, it sounds like we have scaled up, across the country. Different regions are using it differently, but that the hardware, so to speak, the equipment that one needs to be able to provide these services seem to be, you're telling me that they really are, they exist, across the country. And so I will just be interested in the future to see, where we are really kind of pushing that envelope further, and where we can be better partners in the private healthcare delivery as well.
I have one more quick question. Do you measure wait times for telemedicine?
So not specifically for telemedicine. I have some internal data from one of our programs. I just know I look at data, one of our dermatology programs. We're looking at a very exciting program serving a lot of veterans with dermatology, and they're able to turn around an image and a consultation in 1 day on average when they look at their 12-month averages and average them. So there's certainly some exciting areas where the wait times can be reduced, but we don't separate out the services we provide through telemedicine. The wait time for the veteran is still the wait time, and telemedicine is one of our services. So the key is, did we get the patient into service regardless of what modality we used? So we don't have, there may be individual programs doing it better at a national level, and that's not something I'm tracking. There's just the wait time.
That may be something we want to look at. As we move forward, obviously, this is exciting, this is new, this is growing, and through that process, no matter what it is, you're always looking for what becomes the best practice. And that's the work in progress, right? And so I don't think either of us or many people in our audience anticipate that you've got it all down right from the get-go, because it is growing and it is changing, and you've got to also educate patients on the opportunity as well. So it's a mixed bag. And then I think the other thing too is that in implementing this, let's make sure you have the flexibility to do the things that you want to do to provide care, and we don't box ourselves into some type of protocol that may end up doing more harm than good sometimes. You know, we want to have the flexibility to make decisions on behalf of the patients. And so a couple takeaways have to do with the credentialing and the licensing questions that may exist, and I think that may be something we can work on and work with you on that to try and make it very clear as to how this is done. One thing that crossed my mind is no matter where the doc is, virtually he's in the VA or she is in the VA, right? And no matter where the patient is, they are in the same state as the doctor that they're working with. And so maybe we take that concept and apply it to the licensing and be able to take away that burden and make it more flexible and more opportunities for you. But if there's no further questions, the panel is now excused, and I want to thank you all for being here. I think you all have wonderful input for us. And again, thank you, and I want to thank the members of the audience for being here today as well. It's been a pleasure for me to come to sunny California and be with all of you. And hopefully I won't have any problems on my flight back. But with that, I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, so ordered. The hearing is now adjourned. Thank you.